It's really something to think about. How long people used to wait for an MS diagnosis.
Yeah.
We're talking a gap of what, maybe 15, even 20 years sometimes between those first symptoms and finally getting answers.
It's hard to imagine now,
Well,
thankfully.
thankfully, that's shrunk a lot, down to maybe 2 to 5 years now, which is just a massive improvement.
Absolutely huge.
And that progress is exactly why we're diving into today's topic,
Mm-hmm.
the newly revised McDonald criteria for diagnosing multiple sclerosis.
Yeah, this is a really timely discussion because these aren't just like minor tweaks. There's
Yeah.
significant updates. They were presented at Easterns in 2024, Easterns Forum early 2025, and the full details are either just out or coming very, very soon.
So really fresh information.
Exactly. And these revisions, they could genuinely reshape how we understand and, well, how we diagnose MS.
Absolutely. So for this deep dive, we've been looking at expert insights, YouTube videos with neuroradiologists, MS specialists, that kind of thing,
Hmm.
and also grabbing info from the MS Trust website, which is always a great resource.
Very reliable. Yeah.
Our goal today is pretty straightforward.
Yeah.
Let's break down the key changes in these 2024 McDonald criteria
Yeah, let's do it.
and really understand how they're aiming for earlier, more accurate MS diagnoses.
Yeah.
We want to spotlight the most crucial updates and what they mean for, grasping this complex condition. Okay, so
Ah.
let's get into the core of it.
Right. So to really get why these revisions matter, it helps to just understand the basics of how MS is diagnosed and the role the McDonald criteria play in that. Essentially, diagnosing MS, it really hinges on showing two things: dissemination in time, DIT, and dissemination in space, DIS.
Right, DIT and DIS. Heard those terms a lot.
Yeah. Think of it like this. You need to show that damage has happened in the central nervous system. So brain, spinal cord, optic nerve.
The key areas.
The key areas, exactly. But crucially, at different times and in different locations within that system.
Oh, damage spread out in space and time.
You got it.
Right. And it's key, isn't it, that there's no single test, no magic bullet that says, yep, it's MS.
Absolutely not. It's always a combination. Doctors piece things together, what the patient reports,
So
symptoms.
they're experiencing.
Exactly.
Yeah.
Then there's the neurological exam, what the MRI scans show, sometimes a spinal fluid analysis, a lumbar puncture.
Right, the spinal tap.
Yeah. And, of course, the person's medical history plays a big part, too.
So it's detective work, basically.
It really is. And the McDonald criteria, they're like the detective's guidebook. They provide a standardized framework for neurologists to follow during this, often intricate process.
And they've been around a while, haven't they?
Yeah.
Evolving.
They have. First version was 2001, then updates in 2005, 2010, and the last big one before this was 2017.
Okay.
So each revision has kind of built on the last one, driven by, well, our growing knowledge of MS itself and, importantly, advances in our diagnostic tools, especially MRI.
And what were the main aims,
Mm.
right from the start? And with these updates, what were they trying to achieve?
The big goals have always been, number one, get that diagnosis sooner,
Makes sense.
because that means you can start treatment earlier, which hopefully leads to better long-term outcomes for people with MS.
Less disability down the line, maybe.
That's the hope, yeah. The criteria have also aimed to incorporate the better imaging we have now. MRI has become so much more sophisticated. So maybe you could even diagnose MS after just one clinical attack if the MRI evidence is strong enough.
Ah, okay. So you wouldn't necessarily have to wait for a second attack anymore.
Potentially, yes. That was a big shift in earlier revisions. Ultimately, it's about creating a consistent approach. So neurologists everywhere globally can have a common framework, diagnose MS confidently, and get people onto treatments that can, slow the disease down and reduce disability.
Okay, that gives us a really solid foundation. Now let's get to the main event. The major updates in these 2024 revised McDonald criteria. What are the really important changes we need to know about?
Okay, one of the most significant, I'd say, is how they're treating the optic nerve now.
Oh, how so?
It's now recognized as its own distinct fifth topographical location when we're looking for dissemination in space DIS damage in different places.
A fifth location, so it wasn't counted separately before.
Not quite like this. In the 2017 criteria, optic nerve lesions, they were sort of considered, but not as a standalone location for fulfilling DIS in the same way brain or spinal cord locations were.
That seems like a big change, especially because Well, isn't optic neuritis, that inflammation of the optic nerve, isn't that often one of the very first symptoms people notice?
Very often, yes, a classic first symptom for many. So this change really acknowledges that common presentation.
Okay, so how do the new criteria say you can show optic nerve involvement for DIS?
Right. So they specify a few ways. One is finding one or more typical short lesions on an MRI of the optic nerve.
Specific MRI, okay.
Yeah. And importantly, there shouldn't be another explanation for those lesions, and they shouldn't show certain features that might suggest something else is going on, like widespread involvement of the chiasm or signs of paraneuritis.
Got it. What else counts?
Alternatively, an abnormal visual evoked potential test, a VEP test.
Which measures nerve signals from the eye to the brain.
Exactly, how quickly the brain responds to visual stuff. An abnormal VEP peak time can count. Or an abnormal result on optical coherence tomography, OCT.
OCT, that gives those detailed pictures of the retina.
Yeah, the retina and the optic nerve fibers. So abnormalities there can also serve as evidence of optic nerve involvement for DIS.
Wow, so more ways to capture that early visual involvement.
Precisely. And this is really important because it could help diagnose people who first show up with visual symptoms much, much earlier in their MS journey.
That really does sound impactful for those folks. Okay, what else is new in the 2024 revisions? What's another big change?
Another really significant area is the incorporation of more, let's say, advanced information we can get from MRI scans now.
Okay, beyond just seeing the lesions themselves.
Yeah, looking deeper. These are sometimes called advanced imaging biomarkers. They're findings we see on specialized MRI settings that give us more specific clues about the actual underlying changes happening in MS.
Interesting. So what are some of these key biomarkers being brought in?
Two of the most notable ones getting attention are the central vein sign, or CVS,
Central vein signs.
and paramagnetic rim lesions, or PRL.
CVS and PRLs.
That's got it.
Let's start with the central vein sign. What is that?
Okay, so CVS, as the name kind of suggests, it refers to seeing a small vein running right through the middle of an MS lesion.
A vein inside the lesion.
Exactly. But you need specific MRI techniques to see it clearly, usually stronger magnets like 3T or even 7T MRI machines.
Not your standard MRI then.
Not always, no. And specific settings, sequences called susceptibility-weighted imaging, SWI, and T2-weighted images. Those are sensitive to blood products and iron.
Okay, so why is seeing a vein in the middle of a lesion significant? Why does that point towards MS specifically?
Well, it's fascinating, actually. At the microscopic level, we know MS involves demyelination, losing that protective nerve coating. And these areas of damage, these plaques, they often form around tiny blood vessels, specifically small veins or venules.
Okay. The damage clusters around the veins.
That's the understanding, yeah. So when we see that vein centrally located within a lesion on these specific MRI scans, it's thought to be a direct reflection of this paravenular nature of MS inflammation.
So it's like a signature of how MS damage forms.
Kind of, yeah. Now, finding a central vein isn't like mandatory for diagnosis. You don't have to see it.
Okay.
But the new criteria suggest that seeing it in a certain number of lesions can really increase the specificity. It helps distinguish MS from other conditions that might cause white matter spots on a standard MRI.
Makes sense. Helps roll out the mimics. So how is CVS actually being used in the updated criteria? What's the threshold?
The proposed criterion suggests that if someone has 6 or more lesions that show this central vein sign,
6 or more. Okay.
yeah, that can be strong enough evidence to support an MS diagnosis, particularly in certain situations.
Like which ones?
Well, say someone has typical MS symptoms, but their MRI only shows lesions in one area of the central nervous system, like just the brain or just the spinal cord.
So DIS isn't clearly met by location alone.
Exactly. In that case, finding 6 or more of these CVS-positive lesions, plus either evidence of DIT damage at different times or positive spinal fluid findings.
Like the oligoclonal bands.
Right, OCBs, or the newly recognized kappa-free light chains we'll talk about. That combination could lead to an MS diagnosis.
So it adds another important piece of the puzzle, especially in those maybe borderline or less clear-cut cases.
That's the idea. It gives more confidence when maybe the spatial distribution isn't overwhelming.
What does it actually look like on the scan? Can you describe the CVS?
Sure. On the MRI, it typically appears as a very thin, dark line, or sometimes just a small dark dot right in the center of a bright white matter lesion.
Dark line or dot and the bright spot.
Yeah. And to count it, neurologists and radiologists need to see it clearly in at least 2 different image planes, like looking at it from the side and from the top.
Okay, it needs confirmation.
Right. The vein itself should look small, usually less than 2 millimeters wide, and it should run at least part way, if not all the way through the lesion,
Yeah.
and be, centrally located.
Are there times you wouldn't count it? Like exclusion criteria?
Oh, definitely. You wouldn't count it in very, very small lesions, say less than 3 millimeters, or if multiple lesions have kind of merged together, making it hard to tell.
Okay.
Or if you see multiple veins in one lesion, that's not typical for CVS. And of course, if the image quality just isn't good enough to be sure, you wouldn't count it.
Right. Got to be confident. Okay, that clarifies the central vein sign. Now, what about the other one you mentioned, paramagnetic rim lesions? PRLs, what are those?
Okay, PRLs. These are another really interesting finding on those advanced MRI sequences, especially the susceptibility-weighted imaging, SWI.
Same sequence needed as for CVS.
Often, yes, they're sensitive to iron. PRLs appear as a dark rim, like a ring, around certain MS lesions, typically ones that are chronic but still active.
A dark ring around the edge. What causes that?
It's thought to indicate a buildup of iron within specific immune cells called microglia and macrophages right at the very edge of the lesion.
Iron accumulating at the lesion border. Why?
Well, this iron accumulation seems to be linked with ongoing, smoldering inflammation at the edge of these chronic lesions, and importantly, the presence of these rims has been associated with potentially disease progression and maybe more disability over time.
So seeing these PRLs might not just help with diagnosis, but maybe also hint at how active or aggressive the disease might be in that person.
That's what the research is suggesting, yeah. These PRLs seem to correlate with lesions that are chronically active, kind of smoldering away, and potentially a more aggressive disease course.
Okay. And how are they being incorporated into the 2024 criteria? Similar to CVS.
Quite similar in principle, yes. Like CVS, finding PRLs isn't mandatory for diagnosis, but the new criteria proposed that if someone has typical MS symptoms and lesions in only one location again, that situation where DIS isn't clear-cut,
Okay.
then finding just one or more PRLs, plus either DIT or positive CSF findings, OCBs, or kappa-free light chains, can be sufficient for an MS diagnosis.
Just one PRL needed in that scenario compared to 6 CVS.
Correct. The thinking is that PRLs are considered very specific for MS.
How specific?
Research suggests very high specificity, like maybe 99%. If you see a definite PRL, it's highly likely MS or its early stage CIS.
Wow.
And this is important, they have lower sensitivity, maybe around 25% or so in studies looking at distinguishing MS from mimics. Meaning you might definitely have MS but not show any PRLs on your scan. Their absence doesn't rule MS out at all.
Got it. So a strong clue when present, but not finding them doesn't mean much. It sounds like both CVS and PRLs could be really valuable tools. What are their practical challenges with using them? You mentioned the special MRI machines.
Yes, that's a really critical point. These advanced imaging biomarkers, CVS and PRLs, they often require that specialized equipment. Usually the stronger 3T scanners, sometimes even ultra-high field 7T.
Which aren't everywhere.
Exactly. And not just the scanner, but the specific software sequences. And, crucially, radiologists and neurologists trained to accurately identify these sometimes subtle findings.
So there could be an issue with access, right? Like equity.
That's a real concern, yes. It could unfortunately lead to some short-term, maybe even longer-term disparities in diagnostic capabilities depending on where you live and what resources your medical center has. It will likely take time for these techniques to become more widely available and for expertise to build across the board.
That's a really important practical consideration.
Yes,
Okay,
yeah.
let's pivot slightly. You mentioned another update involving spinal fluid biomarkers, specifically kappa-free light chains. How do they fit in now?
Right. This is another significant update in the 2024 criteria. They now state that elevated levels of kappa-free light chains, KFLC, in the cerebrospinal fluid.
The CSF from the lumbar puncture.
Exactly. Elevated KFLC are now considered diagnostically equivalent to finding oligoclonal bands, OCBs.
Equivalent. Okay. For listeners who might not know, what exactly are oligoclonal bands and why have they been so important for MS diagnosis?
Sure. OCBs are basically unique patterns of antibodies, immunoglobulins, that are found in the spinal fluid of a large majority of people with MS, but not typically in their blood serum.
So they're specific to the central nervous system.
Largely, yes. Finding them is a strong indicator of inflammation happening specifically within the central nervous system. For a long time, detecting OCBs in the CSF has been a really key piece of supportive evidence for an MS diagnosis. Sometimes it's even used as a substitute for demonstrating dissemination in time, suggesting past inflammatory events.
Okay. And now kappa-free light chains are considered just as good.
That's what the evidence suggests. Research over recent years has shown that measuring the levels of kappa-free light chains in the CSF is comparable in accuracy to the traditional OCB test for identifying MS.
And is the test different? Easier, maybe.
That's one of the potential advantages. The testing process for KFLC is generally considered simpler, it's often automated, potentially faster, and might be more readily available in some labs compared to the more technically demanding OCB analysis.
Okay. Practical benefits, too.
Exactly. So because of this comparable accuracy and potentially easier testing, the 2024 criteria now explicitly state that elevated kappa-free light chains can substitute for oligoclonal bands in supporting an MS diagnosis.
So it gives doctors another validated tool, especially if OCB testing isn't available or maybe the results are ambiguous.
Precisely. It offers flexibility and potentially streamlines the process in some centers.
Interesting. Okay, what's next on our list of key updates? I think you mentioned something about maybe not always needing to show dissemination in time anymore, DIT.
Yes, this is another change that could be quite significant in certain cases. The revised criteria propose that if a patient comes in with typical MS symptoms,
Okay.
and their MRI shows lesions that meet the criteria for dissemination in space, DIS, in 4 or even all 5 of the typical topographic locations.
And that now includes the optic nerve as one of those 5 potential locations, right?
Correct. So if you have lesions widely distributed across 4 or 5 characteristic areas, brainstem, juxtacortical, periventricular, spinal cord, and now optic nerve,
Okay.
then the requirement to separately demonstrate dissemination in time, DIT, might be waived.
Wow. So if the damage is spread out enough geographically, you might not need that follow-up MRI showing a new lesion or simultaneous enhancing and non-enhancing lesions.
That's the core idea. The rationale is that finding such a widespread pattern of lesions hitting so many characteristic MS spots is already highly specific for MS.
It makes MS the very likely culprit.
Exactly. So the added diagnostic value of also formally proving DIT in those specific cases might be less critical. But, and this is a really crucial but,
Always the but.
always. In these situations where DIT is waived based on extensive DIS, it's absolutely essential that clinicians are extra vigilant in ruling out any other conditions that could potentially mimic MS.
Because some other things could cause widespread lesions.
Yes, though less commonly in this exact pattern. But you still need that careful clinical judgment and exclusion of mimics. You wouldn't want to diagnose MS based only on the lesion map without being sure nothing else fits the picture.
Makes total sense. Okay, careful exclusion is key there. Now let's talk about radiologically isolated syndrome, RIS. We came across this term. What is RIS, and how are the new criteria changing the approach?
Okay, RIS, radiologically isolated syndrome. This refers to a situation where someone has an MRI scan, often done for a completely unrelated reason, like headaches or maybe after a minor head injury.
Right.
And the scan incidentally shows findings that look very typical for MS lesions. But the person has absolutely no history of MS symptoms. They feel perfectly fine.
So the MRI looks like MS, but the person has no symptoms. What was the approach before?
Historically, the approach to RIS has largely been, well, watchful waiting. Monitor the person over time, repeat MRIs periodically, and wait to see if they actually develop clinical symptoms suggestive of MS before making a formal diagnosis and considering treatment.
Kind of a wait-and-see approach.
Pretty much, yeah. Because not everyone with RS goes on to develop clinical MS.
And the new criteria are shifting this.
Yeah.
Maybe diagnosing earlier.
Yes, the 2024 revisions introduced the possibility of diagnosing MS in some individuals with RS even before they develop any clinical symptoms.
Really? How? Based on what?
Specifically, the criteria suggest an MS diagnosis might be possible in someone with RS if their MRI scans already meet the criteria for both dissemination in space, DIS, and dissemination in time, DIT.
Yeah, so if the scans show damage in multiple places and evidence it happened at different times, even without symptoms.
Yes. Or alternatively, a diagnosis could be considered if they meet this criteria and their spinal fluid shows those oligoclonal bands or elevated kappa-free light chains.
Okay, so DIS plus positive CSF.
Right. And perhaps even more strikingly, an MS diagnosis might also be on the table for RS if the person meets DIS criteria and has at least 6 lesions showing that central vein sign we discussed.
DIS plus 6 or more CVS lesions. Wow. So the presence of these specific imaging and CSF markers, even without symptoms, could potentially trigger an MS diagnosis and maybe treatment.
That's the implication, yes. It opens the door to potentially starting disease-modifying therapy earlier in these individuals.
That raises some really interesting, well, ethical questions too, doesn't it? Treating someone who feels perfectly healthy based on scan findings.
It absolutely does. There's a potential benefit. Of course, the hope is you might delay or even prevent the onset of clinical symptoms by intervening early.
Proactive treatment.
Exactly. But you're also talking about starting potentially lifelong medication with possible side effects and costs in someone who is currently asymptomatic. It's a complex discussion, weighing potential benefits against risks and uncertainties. This is definitely an area where we'll see a lot more research and debate.
For sure. Okay, another interesting point from our sources was about stricter guidelines for diagnosing MS in certain groups, specifically people over 50 and those with maybe significant headaches or vascular risk factors. Why the extra caution there?
That's a really important point of clarification in the new criteria. The reason for being more cautious in these groups is that, well, as people get older, and particularly if they have vascular risk factors, things like high blood pressure, smoking history, diabetes, high cholesterol.
Common things.
Very common things. And also people who experience migraines. These individuals are more likely to develop white matter lesions on their brain MRIs that are not due to MS.
What causes them then?
Often things like small vessel ischemic changes, tiny areas of damage from reduced blood flow, or sometimes changes related to migraine itself. And the tricky part is, these non-MS lesions can sometimes look quite similar to MS lesions on a standard MRI.
So it muddies the waters diagnostically, makes it harder to be sure it's MS.
Precisely. The background noise of other white matter changes increases, making the MS signal harder to pick out reliably.
So to be more confident about an MS diagnosis in these specific groups over 50s, those with vascular risks, migraine sufferers, what additional evidence do the 2024 criteria recommend looking for?
Right. So in these specific populations, the revised criteria recommend that to make an MS diagnosis, you need to meet the standard DIS and DIT criteria, plus you need at least one additional piece of supportive evidence.
An extra layer of certainty? Like what?
This additional evidence could be: 1, the presence of at least one definite MS-like lesion in the spinal cord. Spinal cord lesions are less common in mimics like small vessel disease.
Okay. Spinal cord involvement. What else?
2, positive findings in the cerebrospinal fluid, either those classic oligoclonal bands or elevated kappa-free light chains. CSF abnormalities strongly point towards an inflammatory process like MS.
Right, CSF evidence.
Or 3, the presence of 6 or more lesions showing the central vein sign, CVS. Again, using that higher specificity marker.
Okay, so standard criteria plus either a spinal cord lesion, positive CSF, or 6 CVS lesions.
Exactly. Having one of those additional features significantly increases the confidence that the white matter changes seen are truly due to MS and not something else, especially in these populations where mimics are more common.
That seems like a very sensible approach to improving diagnostic accuracy in potentially tricky situations. Okay, lastly, were there any significant updates regarding primary progressive PPMS?
Yes, there was a specific clarification or update related to the dissemination in space, DIS criterion for PPMS.
Okay, what's the change there?
For patients who have progressive neurological symptoms worsening over at least 12 months, that's the hallmark of PPMS.
Right, steady progression.
The new criteria clarify that finding 2 or more lesions in the spinal cord can now be sufficient on its own to meet the DIS requirement for a PPMS diagnosis.
2 or more spinal cord lesions can satisfy DIS for PPMS. Okay.
Yeah, it emphasizes the importance of the spinal cord in PPMS. The other ways to meet DIS for PPMS from the 2017 criteria still apply, of course, like having specific brain lesions in typical areas or having positive CSF findings alongside other lesion evidence. This just adds another pathway focusing on spinal cord involvement.
Got it. So overall, looking at all these changes, the optic nerve, CVS, PRL, CSF updates, RIS, the stricter rules for older patients, the PPMS tweak, it seems like a pretty comprehensive revision.
It really is.
What do you think the biggest impacts will be for patients, practically speaking?
I think the biggest potential wins for patients are, number 1, faster diagnosis.
Getting answers sooner.
Yes. Being able to potentially incorporate optic nerve findings more directly, possibly waiving DIT in some clear DIS cases. These things could really shorten that time from symptom onset to diagnosis for many people.
Which means starting treatment earlier, too.
Exactly. Earlier diagnosis allows for earlier initiation of disease-modifying therapies, which we believe is key to better long-term outcomes.
And what about accuracy? Do these help avoid misdiagnosis?
That's the other major goal, definitely. Incorporating those advanced MRI markers, the CVS and PRLs, gives neurologists tools with higher specificity.
Helps tell MS apart from the mimics.
Precisely. They provide a more detailed look at the lesion characteristics themselves, which can be incredibly helpful when the standard MRI pattern isn't perfectly typical or in those patient groups where mimics are common. It should, hopefully, reduce the rate of misdiagnosis.
Which is obviously hugely important.
Absolutely crucial. However, we do need to temper the excitement slightly with that practical aspect we mentioned.
The access issue.
The access issue, yeah. The widespread implementation of criteria relying on advanced MRI like 3T, 7T scanners and specialized sequences for CVS PRLs might take time. It requires the technology, the trained personnel.
So not everyone will benefit immediately.
Potentially not, no. There might
Yeah.
be a lag as centers adapt and adopt these newer techniques.
That's a fair point to keep in mind. So for our listeners, maybe someone listening was diagnosed a few years ago under the 2017 criteria, perhaps. What might they ask their neurologist now if they're curious?
That's a great question, and it's perfectly reasonable to be curious. I'd suggest asking your neurologist which specific version of the McDonald criteria was used for your diagnosis.
Just to know the baseline.
Exactly. And then you could ask, would these new 2024 updates potentially change anything about my diagnosis or how we understand my MS?
Okay.
Dr. Gretchen Hawley on her YouTube channel actually had some excellent example questions. Things like, based on everything my symptoms, my tests, how confident are you in my MS diagnosis?
Good direct question.
Yeah. Or, can you walk me through my MRI results again? What exactly supports the MS diagnosis there? You could also specifically ask if oligoclonal bands or kappa-free light chains were found in your spinal fluid if you had a lumbar puncture.
Right. Check on the CSF results.
And maybe ask what other conditions were considered and ruled out during your diagnostic process, just understanding the thinking behind the diagnosis.
Those are really helpful, practical questions for listeners to consider taking to their next appointment. Okay, so let's try and bring this deep dive together. What are the absolute key takeaways from our discussion on the 2024 McDonald criteria revisions?
I think the main message is that the 2024 McDonald criteria represent a really significant evolution in how we diagnose MS.
Yeah, seems like a big step.
They're aiming squarely at faster, more precise diagnosis. They do this by bringing in new tools, those advanced imaging biomarkers like CVS and PRLs, recognizing kappa-free light chains as equivalent to OCBs,
Right.
by formally elevating the optic nerve as a key location for DIS, and by refining the rules around needing DIT, especially in cases with very widespread lesions, and adjusting criteria for specific situations like RIS and older patients or those with comorbidities.
And for me, the really striking kind of aha part is how these new criteria leverage technology, using advanced MRI to see inside the lesions, looking for those signatures like the central vein or the paramagnetic rim. The idea that these specific features might help clinch a diagnosis even when the overall pattern isn't perfectly classic, that feels like a real leap forward. And of course, finally giving the optic nerve its proper due as a standalone site is just crucial given how common optic neuritis is early on.
Couldn't agree more. It really highlights how dynamic this field is. Our understanding of MS pathology keeps growing, and our diagnostic tools get more sophisticated to match. It's a continuous process of refinement.
Allowing us to identify MS earlier and hopefully with more certainty.
That's the goal.
So for you, our listener, as you kind of digest all this information, maybe a final thought to consider is, how might these changes ripple outwards? How could these more precise, potentially earlier diagnoses reshape the whole landscape of MS care, treatment strategies, even clinical trial design in the years ahead?
That's a great question to ponder.
It's definitely worth staying informed about future developments and absolutely having these conversations with your own doctors, your own healthcare team. And we definitely encourage you to check out those YouTube channels we mentioned, the Neuroradiologist and Dr. Gretchen Hawley, PT, DPT, MSCS, and the MS Trust website for even more detail on this fascinating topic.